All right, here we go. Kinesiology 230, Chapter 21. We got clients with orthopedic injury or rehabilitation concerns. We are talking presentation number 2 and looking at low back injuries. If we look at low back pain is kind of a catch-all term that encompasses these maladies or issues over here to the left. Dysfunction with the disc, muscle strain. There could be also some strain, sprains of the connective tissue as well. Spinal stenosis, which is kind of a narrowing of the spinal column, spondylosis, and then spondylolisthesis, which we'll talk about here in a second. So you look at this rendering over to the right, you have L1 through L5, that's your lumbar vertebrae 1 through lumbar vertebrae 2, L3, L4, L5. And then you have the intervertebral disc in between each one of them. And the vertebrae themselves do not articulate on top of one another. That disc is in between. It provides some compression in between the discs and allows the vertebrae to articulate in rotational fashion, as well as forward flexion and hyperextension of the low back. And you have different facet joints that are comprised of the spiny processes in the back of the actual vertebrae themselves. So if we look at this, we go, okay, it can be, when you have low back pain, it can be acute or chronic. It can be caused by any number of different conditions, and it can be local to the actual injury itself in the spinal column, or it could radiate, say, to other areas, like down the leg, like if you it's called radiculopathy, but like sciatica, pain that goes down the leg, and somebody feels like a numbness or tingling in their foot, usually is an issue in this area, in the L5-S1 area, and it's the sciatic nerve that comes out and runs down through the hip and goes and services the lower part of the leg is getting some background noise because of an injury in the spine. So there is an interconnected relationship, and the book makes this point, and I'm with it on this 100%, between the hamstrings, the hip flexors, core strength, and low back pain. They kind of all tend to run in the same gang, and one kind of begets the other. And if you think about the hamstrings and where they attach on the ischial tuberosity on the pelvis, and you think of the hip flexors, and you think of everything that crosses from lower body to upper body and upper body to lower body across the pelvis, yeah, it kind of makes sense. If like some of that is out of balance, or one is overly dominant, or you have one side that's weak or long, or another side that's injured, it can cause any number of different issues in the low back. But the book points out that the hamstrings, even though they may be considered a lower extremity muscle group, can cause excessive forward flexion in the lumbar area due to the posterior pull on the pelvis. So they tug on that pelvis at the ischial tuberosity. And this is especially during like different types of movement patterns, and some more than others, but this can result in low back pain. So here the recommendation may be as simple as stretches or exercises directed at increasing hamstring length. And as silly as it sounds, and as simplistic as it sounds, I agree with this, because oftentimes people come in after sitting in a chair all day and in knee flexion, and the hamstrings are just short. And that's it. And then you have to work with your clients to actually get them to lengthen their hamstrings. Now there's also other concerns in terms of strengthening the muscles of the core. Put your fingers in quotes when you say that, in terms of midsection. Things you can do to correct posture, other flexibility exercises as well. Strengthening the hip flexor, strengthening the hamstring, strengthening erector spinae. I mean, you have a whole combo platter of different things you can do to help influence the tug that you see between anterior and posterior pelvic tilt, and being able to maybe eliminate or reduce the back pain that your clients have. It's a case where, when you work with your people, you got to get your hands on them, right, to be able to actually get them to articulate their back. And sometimes you have people who sit all day, and they've been doing that for 10 years, for 9 hours a day, sitting in front of a computer. And so as a result, it's like, it sounds stupid, but it's like their body has forgotten where the hips are, and their body has forgotten how to articulate the hips. And you have to teach them how to do that. I would definitely take a little bit of time to kind of get familiar with the previous the previous diagram, but also this one, we have the body of the vertebrae, and you have the annulus fibrosus, which is, and the nucleus pulpulosus, and those two are part of the intervertebral discs. You know, those discs have kind of a jelly-like substance in there. It's not watery, and the actual discs themselves articulate. So if we were to take the spine here and do like a side bend, well, the material that's inside would actually become kind of pie-shaped and get narrow here like a pie and be wider here. And so it kind of squishes on one side and squishes everything over to one side. If you lean over to the other side, it gets narrow here and makes a big pie-shaped wedge over here. But what ends up happening is this. There's no doubt at some point in your career, you're going to have a client show up and say, I have some low back issues going on. I have a problem with my low back. And they'll come in and say, I have a sore low back and I have no idea what the deal is. Or they'll come in and say, I have a low back. I've been to a doctor. I've been through physical therapy. Now I've been asked to come to go do personal training. And that's how they'll end up in front of you. So I would urge you to, if not only for our class, but for your own career, maybe become a little bit familiar with some of the terminology surrounding the intervertebral discs and the construction of them and how they articulate when the spine actually moves. All right. They do make some broad recommendations regarding specific exercises and movement of the lumbar region. Here's a couple to commit to memory. Therefore, they should avoid exercises involving significant lumbar flexion and should perform strengthening and stabilization activities in natural lower doses. Resistance training contraindications may include full sit-ups, while precautions may include the squat, all rowing movements, and the deadlift. And I would tell you, with some people, trying to put a bar on a person's shoulders and adding that compressive force to their spine and asking them to do a squat, forget it. There's no way. You may have to re-educate them on just how to do a freestanding squat without any load. But what you see here to the right, I would definitely take a few minutes just to pause me and kind of like commit that to memory for your future use, if you will. All right. Spondylosis and spondylolisthesis, they sound pretty darn close and sound pretty similar, but but one is an extension of the other. So with spondylosis, you look at that, it's a stress fracture. And remember I mentioned those spiny little processes that are on the back of each lumbar vertebrae? Well, spiny little processes, they can be cracked or they can fracture. You can imagine like a linebacker, taking on a block, or even an offensive lineman taking on a defensive lineman, and they have a big arch in their back. As the spine articulates backwards, you can have one process bump into the other process and cause a fracture. Fall, land on your back, that can cause a fracture. The fracture itself is a spondylosis. That's a crack there. But when you have a spondylolisthesis, the difference is it's a complete fracture, and notice there's separation. It's actually free floating at that point. That's your big difference between those two, just in case you're ever asked again. So the causes can vary. There can be any number of different things that cause either one of those, but just realize one is spondylosis is a fracture. The spondylolisthesis is a complete, basically a compound fracture, if you will. It breaks off from the bone itself. All right. With this, you have disc injury to the left, muscle strain, spondylosis, and acute or subacute spondylolisthesis. They break this out into movement contraindications, the things that you shouldn't do, the exercise contraindications, the things you shouldn't do, and then exercise indications. These would be the things that you should do. So in terms of exercise, if you have somebody who does have a spondylosis or spondylolisthesis, we're staying out of lumbar extension. We're not doing squats. We're not doing shoulder press or push press. And one could imagine the forces on the lumbar area of the spine. But these we would do: knees to chest stretch, abdominal crunch, pelvic neutral stabilizations, isometric gluteal strengthening. I will say this though, given the nature of these injuries, because they are a fracture, either hairline or complete fracture of the spiny process on the low back, laying on one's back might be uncomfortable, so you may have to play around with if you have people do this or not. All right, I'm going to get out of this and go on to the next presentation. And I'll just say this regarding low back stuff, 100%, you're going to have clients who come in with low back injuries or issues. I would make it a point to learn as much as possible about this particular area. There's a lot that goes into it, and there's a lot of musculature that crosses the hip region, and it all has an effect on the pelvis and the low back. All right.